Okay, moving on to the adrenal gland. Recall that the adrenal gland is actually two organs in one. There's an adrenal cortex, which secretes hormones derived from cholesterol. And then there is a adrenal medulla, and the medulla, of course, secretes catecholamines such as epinephrine and norepinephrine. We're going to begin our discussion with the adrenal cortex, and then we're going to move on to the medulla. Now, before we can discuss the cortex, you need a little bit of background, and so let's recall from histology that the adrenal cortex actually has three layers: a glomerulosa, a fasciculata, and a reticularis. Now, that's pretty easy to remember. One of the mnemonics that people like to use is GFR. Remember that the adrenals sit on top of the kidney, and of course in the kidney, one of the key things that we always talk about is a GFR, and so it shouldn't be hard to remember that in the adrenal gland, you're also going to think about GFR. Again, glomerulosa, fasciculata, reticularis. Now, you also need to remember that all of the hormones that are produced by the cortex are going to be derived from cholesterol. In fact, if you recall from anatomy, when you look at the adrenal, it has a very distinct yellow color, and that's because it's loaded with cholesterol, which is eventually going to be used to make all of these hormones. Now, cholesterol in the glomerulosa will eventually generate mineralocorticoids such as aldosterone. And of course, aldosterone is important for salt maintenance. Cholesterol will also eventually generate cortisol, and cholesterol will also eventually generate the sex steroids. And one of the mnemonics that some students like to use to remember this is, quote unquote, it gets sweeter as you get deeper, i.e. this is salt, this is sugar, because cortisol is important for maintaining sugar as well, and this represents sex steroids. And so I tell you that the adrenal gland is composed of three layers: glomerulosa, fasciculata, reticularis. And of course, the glomerulosa generates mineralocorticoids such as aldosterone. The fasciculata generates glucocorticoids such as cortisol, and the reticularis generates sex steroids. The first disorder is Cushing syndrome, and in Cushing syndrome we have an excess of cortisol. The clinical features of Cushing syndrome will all be based on the physiology of cortisol. One of the important things that cortisol does is to raise the blood sugar, and one way by which it does this is to break down muscle for gluconeogenesis. So patients with Cushing syndrome are going to have muscle weakness with thin extremities, and again, that's because you're breaking down muscle to provide the amino acids necessary for gluconeogenesis. In addition, the patients will have moon facies, buffalo hump, and truncal obesity. Now, the idea here is that if you have gluconeogenesis, you're going to have a high glucose in the blood. The high glucose is going to result in excess insulin being produced by the pancreas. The excess insulin will then result in the storage of fat. And so fat will be stored in the face, on the back, and on the trunk. An additional consequence is that the patients will develop abdominal striae. The reason for this is that cortisol impairs the synthesis of collagen. And so when you have weak collagen, the blood vessels can rupture easily, and so you'll get these striae on the abdomen, which basically represent ruptured blood vessels. The patients can also develop hypertension. The idea here is that cortisol upregulates alpha-1 receptors on the arterioles, which then increases the effect of norepinephrine. Remember that cortisol is necessary for life, and the reason it's necessary for life is because it helps to maintain vascular tone. And so the way by which it maintains vascular tone is upregulation of alpha-1 receptors on arterioles. And so when you have excess cortisol, you'll have excess alpha-1 receptors, which will then increase the effect of norepinephrine, giving the patients hypertension. That's particularly high yield. The patients can also develop osteoporosis. And finally, the patients can also get immune suppression. And we're well aware of the fact that cortisol is used as an immunosuppressant, but it's important to go back and remind ourselves why. And so there's three major mechanisms by which cortisol results in immune suppression. Number one is that it inhibits phospholipase A2. And recall that if you inhibit phospholipase A2, you won't be able to generate your arachidonic acid metabolites. And of course, those are essential for inflammation. Number two is that it inhibits IL-2, and IL-2 is an important T-cell growth factor. And number three is that it inhibits release of histamine from mast cells. And of course, histamine is essential for vasodilation and for increased vascular permeability. And so all three of these are mechanisms by which you get immune suppression in patients with Cushing syndrome. The diagnosis of Cushing syndrome is made by detecting an increased 24-hour urine cortisol level. And when you think about the causes of Cushing syndrome, there's actually four major causes. The first would be exogenous corticosteroids. And so the idea here is that we prescribed corticosteroids to the patient, and as a result of that excess corticosteroids, the patient will develop Cushing syndrome. This is actually the most common cause of Cushing syndrome. And one of the important consequences with exogenous corticosteroids is that both adrenal glands in this case will actually become atrophic. Now let's just go back and remind ourselves, when you have excess cortisol within the blood, that cortisol will go to the anterior pituitary and shut down the production of ACTH. When you shut down the production of ACTH, that's then going to result in both adrenal glands becoming small. And so you have bilateral adrenal atrophy with exogenous corticosteroids. A second possible cause of Cushing syndrome could be some adrenal problem. For example, you can have an adenoma, you can have hyperplasia, or you can have a carcinoma within the adrenal, and that could produce cortisol. And so in this particular case, what's going to happen, the high cortisol obviously would give you Cushing syndrome, but what's going to happen is one adrenal will be big, and this is, for example, the adrenal gland that has the adenoma. That adrenal is going to be secreting cortisol. Cortisol will then go into the blood. It'll then go and hit the anterior pituitary. That'll shut down ACTH, and when it shuts down ACTH, the opposite adrenal will actually become atrophic. And so one adrenal gland will be big, i.e. the one that has, for example, the adenoma, and the other will be atrophic. A third way by which we could develop Cushing syndrome would be to have an ACTH secreting pituitary adenoma. Now in this particular case, what's going to happen is that the adenoma and the pituitary will secrete ACTH. The ACTH will hit both adrenals when it goes into the blood and make both adrenals big. Now when both adrenals are hit by ACTH, both adrenals will produce excess cortisol, and that excess cortisol will obviously result in Cushing syndrome. The fourth possibility is to have paraneoplastic ACTH secretion. Now in this particular case, you have a tumor. Most classic example would be a small cell carcinoma of the lung. The tumor secretes ACTH. That ACTH goes into the blood. It hits both adrenals. When it hits both adrenals will then become large, and both adrenals will produce cortisol, which will result in Cushing syndrome. Now notice that when you look at these four possibilities, this possibility is unique in the sense that it's the only one that gives you atrophy of both adrenals. And this is unique in the sense that you'd see one adrenal large with a mass and the other adrenal atrophic. However, when you look at these two, you can't distinguish based on the size of the adrenals. And so you can actually do an additional test to try to distinguish an ACTH secreting pituitary adenoma from ACTH secretion that arises from, for example, a small cell carcinoma of the lung. And the way by which you do this would be to do a high-dose dexamethasone suppression test. The idea here is that when you give high-dose dexamethasone, which is a cortisol analog, it has the ability to suppress ACTH production by a pituitary adenoma. However, it will not be able to suppress ectopic ACTH production by a small cell carcinoma of the lung. The way I think about this is sort of the high-dose dexamethasone gets into the blood, it goes up to the pituitary adenoma, and it slaps the pituitary adenoma and says, wake up, you're actually still a benign pituitary cell. And so then the pituitary adenoma responds by shutting down its ACTH production. However, when high-dose dexamethasone goes up to the small cell carcinoma of the lung and tries to slap it back into shape, the small cell carcinoma of the lung just slaps it back because it is a cancer. It is not going to listen to or respond to anyone. And so therefore, high-dose dexamethasone will not shut down ACTH production by the small cell carcinoma of the lung. The final point is that when you do this high-dose dexamethasone suppression test, you'll actually follow the effect by measuring cortisol levels. So the dexamethasone will then decrease the ACTH production by the adenoma, for example, which will then decrease the amount of cortisol being produced, and so you'll be able to detect decreased cortisol levels. Hyperaldosteronism is when you have excess aldosterone, and the effects of excess aldosterone will all be based on the normal physiology of aldosterone. So let's go back and just remind ourselves before we go to the text that aldosterone works on the late distal tubule and the collecting duct. And in this region there are two main cell types. There is the principal cell and there is the alpha intercalated cell. Now the principal cell, in response to aldosterone, will actually grab sodium and will dump potassium. And the alpha intercalated cell, in response to aldosterone, will actually dump hydrogen ion. And so now you can imagine that if a patient has hyperaldosteronism, they're going to get hypernatremia because they're grabbing sodium, they're going to get hypokalemia because they're dumping potassium, and they're going to get a metabolic alkalosis because they're dumping hydrogen ion. And so this is the key findings as I've stated here in the text. I say that the presentation is hypernatremia, you're grabbing sodium, hypokalemia, you're dumping potassium, and a metabolic acidosis because you're dumping hydrogen ion. Now, of course, the patients will also have hypertension, and that's because when you grab sodium, water is going to follow, which is going to raise the blood volume. In primary hyperaldosteronism, the high aldosterone is due to a primary problem within the adrenal gland, and this would most commonly be due to a benign tumor of the adrenal gland called an adrenal adenoma. It is also possible to have primary hyperaldosteronism due to hyperplasia or carcinoma of the adrenal gland. However, these are much less common causes. Now, in this particular case, you're going to have a high aldosterone because you've got primary hyperaldosteronism, and you're going to have a low renin. Now, recall that when you have high aldosterone, you're going to grab sodium, and water is going to follow, and that's going to raise the blood volume. That high blood volume is then going to go to the kidney, so the kidney is going to see high blood flow, and so therefore it will decrease the production of renin, and so you'll have a low renin. And that's particularly high yield when thinking about primary hyperaldosteronism. In secondary hyperaldosteronism, you get a high aldosterone. However, it's secondary to the fact that you have activated the renin-angiotensin system. Now, recall from our vascular lectures that if this is the aorta and this is the renal artery and this is the kidney, there's a couple ways by which this could occur. Classically, in a young woman, you can get something called fibromuscular dysplasia, which results in thickening of the wall of the blood vessel, which would then decrease the blood flow to the kidney and therefore activate the juxtaglomerular apparatus. Or you could get atherosclerosis, particularly in elderly males, which would then decrease the blood flow to the kidney, also activating the juxtaglomerular apparatus. Now, recall from physiology that when you activate the JGA, or the juxtaglomerular apparatus, you're going to then secrete renin. So you're going to have a high renin. Of course, the renin converts angiotensinogen to angiotensin 1. Angiotensin 1 then gets converted by angiotensin-converting enzyme to angiotensin 2. And then angiotensin 2 goes to the adrenal gland and causes release of aldosterone. And so you're going to have high aldosterone because of the fact that you activated the renin-angiotensin system. Congenital adrenal hyperplasia is when you have hyperplasia of both adrenal glands due to a congenital defect in the enzymes necessary for steroidogenesis. The most common deficiency is a 21-hydroxylase deficiency. However, before you can understand this, we need to go back to the whiteboard. Remember that cholesterol is the starting point for steroidogenesis in the adrenal cortex. It gets converted to pregnenolone, and pregnenolone can enter into one of three pathways. It can produce mineralocorticoids, it can produce cortisol, or it can eventually produce sex steroids. Now, in order to produce mineralocorticoids, you need 21-hydroxylase, and in order to produce cortisol, you need 21-hydroxylase. Imagine if there's a deficiency of 21-hydroxylase here and here, then pregnenolone will be shunted to the preferential production of sex steroids, and so the sex steroids will increase. Now, the consequence of this is that the patient can get clitoral enlargement if they're a female, or they can get precocious puberty if they're a male. In addition, there's going to be a lack of cortisol because you can't produce cortisol. This will result in decreased cortisol in the blood, and the decreased cortisol in the blood can result in, number one, life-threatening hypotension, because remember that cortisol is necessary for life, and in particular it helps to maintain vascular tone, and so you can get life-threatening hypotension. And number two, because you have decreased cortisol, you're going to have decreased inhibitory feedback on the anterior pituitary, so there'll be excess production of ACTH. The excess ACTH will get into the blood, it'll hit both adrenals and make both adrenals big. And in fact, that's why we call it congenital adrenal hyperplasia. Now, the third consequence of having this defect of 21-hydroxylase will be that you won't have mineralocorticoids. When there's a loss of aldosterone, for example, you'll get salt wasting. Now, remember that aldosterone normally grabs salt and dumps potassium. So if you're lacking aldosterone, you're actually going to lose salt, i.e. salt wasting, and you're going to hold potassium. And so the patients will actually get salt wasting with hyponatremia and hyperkalemia because they're holding potassium. And at the same time, normally because sodium would come in and water would follow, in this case, you're not going to be bringing back sodium, and so you're not going to be bringing back water, and so the patients can also become hypovolemic. Now, with this background in mind, let's go back to the text. So I say that 21-hydroxylase deficiency is the most common cause of congenital adrenal hyperplasia. The steroidogenesis will be shunted towards the production of sex steroids, and the fact that there will be a deficiency of cortisol will lead to increased ACTH from the anterior pituitary. Again, you're lacking feedback on the anterior pituitary, which is then going to result in bilateral adrenal hyperplasia. The clinical features will be salt wasting. Again, lack of aldosterone, so you can't grab salt, so you'll waste it, and you'll get hyponatremia. And you'll have hyperkalemia. Again, normally aldosterone would dump potassium, but you're going to hold potassium. And there'll be hypovolemia because you're not bringing in salt. There'll also be life-threatening hypotension because of the low cortisol. And finally, the patients can have clitoral enlargement if they're a female, or precocious puberty in a male, and that's because of the increased sex steroids. Now, I'd like to actually take this one step further, although your text doesn't, just to add a couple things because it's easy to do so here and they're potentially high yield. Let's just remind ourselves that cholesterol is a starting point of steroidogenesis. It can result in the production of pregnenolone, and pregnenolone can eventually enter into one of three pathways. It can lead to the production of mineralocorticoids, or cortisol, or sex steroids. In order to produce cortisol, you need both 21-hydroxylase and 11-hydroxylase. In order to produce weak mineralocorticoids, you need 21-hydroxylase. And in order to produce the next level of mineralocorticoids, you need 11-hydroxylase. This is important because remember, when you lose 21-hydroxylase, you don't produce mineralocorticoids and you don't produce any cortisol. And so the patients have salt wasting with all of the symptoms that I've already described. However, imagine if you had an 11-hydroxylase deficiency. You'd also not be able to produce cortisol, and you'd also get some shunting towards sex steroids. However, you would produce a little bit of a weak mineralocorticoid, and so you wouldn't have the salt wasting. And so on board examination, if they give you the classic history of someone with a 21-hydroxylase deficiency, however, the patient doesn't have salt wasting and doesn't have hyperkalemia and doesn't have hypovolemia, then you need to remember that it's not a 21-hydroxylase, but instead it's an 11-hydroxylase problem. And that's particularly high yield, so I'm taking a minute to just explain that to you. Now, one more possibility, just in case examiners go after it, and that is that in order for pregnenolone to enter into the pathway to develop cortisol and sex steroids, you need 17-hydroxylase. Now imagine if you're lacking 17-hydroxylase, then you won't be able to produce anything on this side, and the only thing that you're going to produce is excess mineralocorticoids. And so if there's a 17-hydroxylase deficiency, the problem will be excess mineralocorticoids with no cortisol and no sex steroids. Now notice one thing, and that is that in all of these deficiencies, 17, 21, and 11, you're always not producing cortisol. And so because you're always not producing cortisol, you're always going to have excess ACTH because of a lack of feedback. And so each of these cases would result in congenital adrenal hyperplasia. Adrenal insufficiency is when you have a lack of adrenal hormones, and adrenal insufficiency can actually occur acutely or it can occur chronically. When it's acute, the classic high-yield example is Waterhouse-Friderichsen syndrome. This classically arises in a young child with a Neisseria meningitidis infection who develops DIC and then gets bilateral necrosis of both adrenal glands. And of course, that then results in an acute lack of cortisol. The acute lack of cortisol would then exacerbate the patient's hypotension. Now, of course, they've already got Neisseria meningitidis and DIC. However, on top of that, they then get this massive hypotension due to a lack of cortisol. And so this is particularly high yield. Now, here's a classic example. Notice that this is the adrenal gland here. And you can see that this adrenal gland has been converted to a sac of blood. And that's the classic image that they like to show. It's a very common image that shows up on board exams. So the sac of blood adrenal. And this again represents Waterhouse-Friderichsen syndrome classically. Chronic insufficiency is when you get slow progressive destruction of the adrenal glands. And there are three major causes that are high yield for the board exam. The first is autoimmune destruction. This is the most common cause in the West. The second is when there's destruction of the adrenal glands by TB, and this is the most common cause in the developing world. And the third is when there is metastatic carcinoma that metastasizes to both adrenals. And this is a very common cause on board exams. And the particular example here that you want to bear in mind is that lung cancer loves to go to the adrenal, very high yield. Lung cancer loves to go to the adrenal. Now, the clinical features of chronic insufficiency are going to be based on a lack of the hormones normally produced by the adrenal. So you're going to get hypotension. Why? Because you don't have cortisol, and cortisol is necessary to maintain vascular tone. You're going to get hyponatremia, hypovolemia, and hyperkalemia. Again, you don't have aldosterone. Aldosterone normally grabs sodium, so because you don't have it, you're going to dump sodium. Aldosterone normally dumps potassium. Because you don't have it, you're going to hold potassium. And because you don't have sodium, you're also going to lose volume. Patients can also get hyperpigmentation. The idea here is that if you don't have cortisol, you're not going to be able to negatively shut down the production of ACTH by the anterior pituitary, so there'll be excess production of ACTH. Now, ACTH is actually derived from a molecule called POMC, and one of the derivatives of POMC is melanocyte stimulating hormone, which will then stimulate the melanocytes, resulting in hyperpigmentation. And it classically arises in the oral mucosa, but it'll also be present on the skin. And then the patients also have vomiting and diarrhea, again due to a lack of cortisol. Moving on to the adrenal medulla, recall that the adrenal medulla is composed of chromaffin cells, very high yield for board exams. These are derived from the neural crest. They are the main physiologic source of catecholamines, and so both epinephrine and norepinephrine are released by the adrenal medulla. The key pathology that we want to cover is called a pheochromocytoma. A pheochromocytoma is when you have a tumor of the chromaffin cells. Now, when you get a tumor of the chromaffin cells, the classic finding on gross exam, and very high yield to know, is that you get a brown tumor. Now, that's because the adrenal medulla is brown, and so if you get this big tumor here of the adrenal medulla, of course, it's also going to have the same color, which is brown. Now, notice here that you see this little yellow line running along the edge of the tumor, and do you know what that is? That little yellow line represents the adrenal cortex. And of course, the adrenal cortex has a yellow color because it's loaded with cholesterol, which is the starting point for the production of steroids. The clinical features of pheochromocytoma will be episodic hypertension, headaches, palpitations, tachycardia, and sweating. All of these are a consequence of epinephrine and norepinephrine. The diagnosis is made by detecting increased serum metanephrines and increased 24-hour urine metanephrines and VMA. Now let's go back to biochemistry and remind ourselves that if you have epinephrine and norepinephrine, the epinephrine will be broken down into metanephrine, and the norepinephrine will be broken down into normetanephrine. These two, both metanephrine and normetanephrine, will be broken down into VMA. And of course, the enzyme that does this is monoamine oxidase. Now, this is particularly high-yield biochemistry because, of course, if you've got a tumor that's producing epinephrine and norepinephrine, then one way by which you can make the diagnosis is to detect increased metanephrines or increased VMA. And so that's what we're saying here in the text. Let's go back to the book. Diagnosed by increased serum metanephrines and increased 24-hour urine metanephrines and VMA. So again, that's particularly high yield. Now, the treatment is surgical excision. However, it's very high yield to know for the purposes of board exams that before you remove the tumor, you're going to give the patients phenoxybenzamine, which is an irreversible blocker of alpha receptors. Now, the idea here is that when the surgeon goes in to remove the tumor, if they grab the tumor, when they squeeze it, they could actually squeeze out epinephrine and norepinephrine. That can result in massive hypertension in the patient and can actually result in death. And so in order to avoid the effect of this surge of epinephrine and norepinephrine, patients are given phenoxybenzamine before the tumor is removed. Additional features of pheochromocytoma are remembered via the rules of 10. 10% are bilateral, 10% are familial, 10% are malignant, i.e. 90% are benign, and 10% are located outside of the adrenal medulla. Now, it's very high yield to note that one classic location outside of the adrenal medulla would be the bladder wall. And so on a board exam, if you have a patient that when they urinate develops episodic hypertension, etc., think about a pheochromocytoma involving the wall of the bladder. And again, that's particularly high yield as well. Now, a few associations with pheochromocytoma to close off this discussion. The first is that patients with both MEN2A and MEN2B can develop pheochromocytoma. Just as a review from earlier in this section, remember that MEN2A is medullary carcinoma of the thyroid, pheochromocytoma, and parathyroid adenoma, and that MEN2B is medullary carcinoma of the thyroid, pheochromocytoma, and mucosal ganglioneuromas, especially in the oral mucosa. Now, also remember from earlier in this section that the key thing about MEN2 overall is that medullary carcinoma of the thyroid is the key thing that would kill the patient. And so one way we can avoid developing the cancer would be to remove the thyroid. And remember that there's a key gene that you want to test for before you remove the thyroid to determine if there's a genetic risk. And what's that gene? RET. Again, the association of RET mutation leading to medullary carcinoma of the thyroid is very high yield for board exams. Von Hippel-Lindau disease is an autosomal dominant condition where you lose the von Hippel-Lindau tumor suppressor gene. We talked about this disease in the renal section. Remember that the patients have an increased risk of hemangioblastoma of the cerebellum and an increased risk of renal cell carcinoma. And now I'm telling you that there's an increased risk of pheochromocytoma in those patients as well. And finally, in neurofibromatosis type 1, patients get neurofibromas, but they can also develop pheochromocytomas. And so that's an important association for board exams as well. And that concludes both this section as well as the endocrine chapter.